This mini lecture is going to cover psoriasis, and we're just going to briefly touch on a few insect bites that you may see come through the office in primary care. Psoriasis affects almost 3 million Americans annually and 2 to 4% of the population worldwide. It's universal in occurrence, but the prevalence varies according to geographic, the race, and also ethnicity. So if you're thinking about different areas in the world, there are almost no cases in South Americans living in the Andes, and only 3% of the population may get it that live in Denmark. It's less frequent among Asians and among North and South American native people compared with the people of European ancestry. It is less frequent in West Africans, which may explain why there's a low prevalence in African Americans. The prevalence is highest among Scandinavians because of the role of the climate and the sunlight exposure. So the rates are usually higher in the northern end of Sweden than in the southern end of Sweden. It is a common chronic scaly rash that affects all people of all ages. There's also a genetic disposition to this where there's been some family studies that have been done, and when one parent is affected, 8% of the offspring develop psoriasis, and they tend to have it at an earlier onset. But when both parents have been documented to have psoriasis, then the incidence increases to about 41%, and they really are not sure how the transmission occurs. There are many different variants to psoriasis, but the one we're really going to cover is plaque psoriasis because it is the one that's most commonly found in adults, and it is probably accounts for about 80% of the psoriasis that you're going to see in primary care. Adult men and women are affected with equal frequency, and the two peak ages at onset are during the late teens to early 20s. So usually before the age of 30, they'll get this, and then maybe into the 50s to 60s. It is a chronic condition. It does come with remissions, and it also comes with flares, and there's certain things that can lead to that. And stress is one of the big ones because it's really hard to avoid stressful environments, and physical and emotional stress take a toll on the body. So these patients will come in and they'll be under a really having some really stressful times in their life, and they'll have breakouts. They'll have a flare up. Also, some infections can cause the flares of psoriasis, but also when you're treating that infection, sometimes it helps to improve the psoriasis also. Injuries, so physical, chemical, electrical, infective, inflammatory injury. Psoriasis can all localize around that site as it starts to heal, but it's very uncomfortable for the patient in those areas. And then we have medications that really can precipitate or aggravate psoriasis. There's lithium. We have the beta blockers as well as systemic corticosteroids and the beta adrenergic the beta blockers and the anti-malarial drugs also. These all can cause some difficulties with patients having psoriasis. So when you're prescribing these medications, you need to think about that if they already have this diagnosis. Some of the treatments that are used are the systemic non-biological medications, such as methotrexate, which is very effective for plaque-type psoriasis, as well as the biologic agents that are effective. And these are used only if the psoriasis cannot really be controlled by topical therapy or by phototherapy. So we're looking at Rumitrex, Trexall, Humira, Enbrel, all of these medications. Methotrexate is a folic acid antagonist and a cytotoxic agent, and it does inhibit the cellular proliferation. We use it in chemotherapy patients for cancer, but it's also very useful in patients who have severe psoriatic arthritis. With prolonged use, there is accumulative doses, there's accumulation of methotrexate in the body, so they can get that hepatotoxicity as well as nephrotoxicity and also bone marrow depression. So it is contraindicated in any patients who have liver disease or diabetes or history of alcohol or IV drug use. But these pretty much you're going to be sending out to dermatology or rheumatology to be managing these patients. We don't usually prescribe these in primary care. I don't prescribe them in primary care. Wherever you go may do that, but I don't know too many primary care physicians who or nurse practitioners who do prescribe these. Phototherapy is also another option, and it's indicated for generalized psoriasis. This is usually done also by a dermatologist in his practice. And some patients do really, really well with this. Other patients don't do as well with it, but they're using the UV light because of the potential. You have to be cautious because of that potential cataract formation when they're using this UV light. And because of the significant occurrence of nausea as well as body aches and the phototoxic erythema, premature aging of skin, all of this is concerns when the treatment is being done with these patients. Although it can clear chronic plaque psoriasis in about 6 to 8 weeks, it can also cause overexposure. So you have to be real cautious with using it, which is one of the reasons why we send these patients out. About 5% of those with psoriasis also develop psoriatic arthritis, which can be very debilitating for some patients, and about 50% get that nail involvement. And I'll show you a really good picture of this as we move forward in the slide presentation. But most commonly, you're going to see this plaque psoriasis develop, and this is the one mainly we see in primary care. This disease often is categorized by severity. So if they have less than 5% of the body surface area covered, it is considered a mild to moderate disease. And it does not usually occur on the genitals, the hands, the feet, and the face. If it's moderate to severe, and it may affect over 5% of the body surface area on those specific areas. But most of the time, you're not going to see psoriasis in those areas. It is very well defined. There's sharply demarcated red plaques with scaly patches on them. And 80% of patients have plaque psoriasis is mild to moderate disease. Only 20% usually have it where it's affecting all other areas of the body. It is mainly seen on the knees and the elbows and in the creases of the extensor. Bilaterally, usually symmetrical, and you may also see it on the scalp or the sacrum area. It is a very scaly, typically silvery white patch, and if you scrape it with a tongue blade, it will bleed. We call this the Auspitz sign. Many times patients will come in and they will try to see if they'll try to get a skin scraping of it, and that's kind of how it ends up being. You get that fine pinpoint bleeding. The lesions are usually distributed over areas of bony prominences, so the elbows, the knees, and sometimes and many patients won't even see it on their scalp. If you're thinking about the scalp or the trunk or the umbilicus, these are usually overlooked by the patient and usually by the clinician, but they're important in making a diagnosis, especially if you're trying to determine if it's just psoriatic arthritis or limited skin lesions. So we're looking to do a thorough exam of the skin surface before you're going to do the diagnosis. Another helpful diagnostic feature is that Koebner's phenomenon, which I talked about earlier, where there's intense trauma which has induced formation of new skin lesions. So that's from that excessive rubbing and friction. The typical scale may not be so obvious if the psoriasis affects the body folds. So it may be more likely to be smooth, it may not itch, or it may itch. So usually they'll present to the practitioner with that itchy, red, inflamed, dry, scaly plaque, and they'll say it's just gotten worse. It can also have a very explosive onset, and that could be related to, a strep infection. So if someone has a severe strep throat, which, down the road will lead to about maybe 2 to 3 weeks, you'll start seeing those plaques starting to form. Once the disease disappears, it does follow an irregular, chronic, unpredictable course. So it may even remain localized to a few areas, or it may cause some intermittent or continuous generalized lesions. When we're thinking about treating these patients, sunlight is always beneficial, which is one of the reasons they do that UV management, the phototherapy on these patients. Some patients find the presence of even just a few small plaques highly objectionable because the location is highly visible and they find it disfiguring. It may hinder their physical activity. So we try to treat them the best that we can. It can have a psychological impact on their quality of life, just because of that. So topical medicines are mainly used for limited diseases, and there's several that we can go into and talk about. They go anywhere from low potency topical corticosteroids all the way up to super high. So when we think of super high, we're thinking of the betamethasone at a 0.05%. We're thinking of fluosinide at a 0.1%, clobetasol propionate at a 0.05%. But then as you go down and you move lower to from high to intermediate to low, the fluosinide acetonide goes down to a 0.01% versus a 0.1%. So they kind of go down in range. Betamethasone drops from a 0.05% down to a 0.12%, excuse me. So they go down in the percentages. You can still use the same medication, but the percentages actually change. So you're going from medium to high potency, which is a class 3. There's also some vitamin D analogs such as Dovanox that you can use, and some topical steroids as effective as vitamin D with less local side effects. But so you want to start usually in that medium range and go up instead of starting in the low, because the low you're really not going to see any results with. When are we going to refer them? Well, if they have over 20% body surface area involvement, they need to be referred. If they're not responding to treatment after 4 to 8 weeks, they need to be referred. And as I said, anyone requiring those special agents with phototherapy need to be referred. I would not do any of those in primary care. And this is a really good picture of the plaque buildup. You can see that erythemic demarcated border with the silvery patches on the top of it. Once you see a psoriasis, you'll always know what it looks like. It's very classic. And this is the pitting of the nails. You can see that there's some striation in the nail. It almost looks like a fungus that could be starting under the nail, and this can be missed very easily. Patients can tell you they think they have a fungal infection, and you may start to treat them for a fungal infection when indeed it is just the psoriasis getting underneath the nail. So this is a good reason why it's good to send them to dermatology to do a nail scraping, and for them to get the scrapings and make sure that you're treating it appropriately. You can also see the little holes inside the nail where it doesn't go all the way down, but it actually is a pitting effect. And now we're going to talk just very briefly on insect stings and brown recluse spider bites, because these are things that you're going to see patients come in primary care with these little stings. Some of them are big stings and some of them are little stings. And brown recluse spider bites are very scary. Okay, we can have a lot of venomous stings. We can have bee stings. We can have wasp stings, hornet stings, even fire ant stings. But one of the biggest areas of problem is when you get into a brown recluse, or you get into these bites where they actually cause anaphylactic reactions to occur. I had a patient one time who I had just become a nurse, and I was working in a medical ICU, a high-level medical ICU, and they transferred this patient from another hospital into our hospital, and she was on a ventilator, and she subsequently died. She was 32 years old. She was out in the yard working with her husband. She knew she was allergic to ant bites, and fire ant bites, and she was out working in the yard, did not realize she got bit, because sometimes these are, living in Florida, I can tell you I've had bites on my legs before, and my arms. I never even felt the ant on me. So they can bite you before you even know that they're on you. And so she went in to go to the bathroom, and she didn't come back out, and her husband went in, and she was out on the floor, non-responsive, and he tried to do CPR on her. They put her on a ventilator, and she subsequently died from the fire ants. So she probably went into an anaphylactic shock. But these things are nasty, especially where you live down in the southern states. I live in Florida, so down here we have them horrible. We get big mounds of them in our backyard, and you have to actually kill the queen in order to get rid of the whole ant pile. And there's times I've run over them with the lawnmower, and there's millions of them that just come flying out of this mound. So they're very scary, they're very concerning, and they can actually kill people. So this is one thing to think about. Treatment of mild anaphylaxis, if there's no involvement with respiratory difficulties, you may be able to just give them some epinephrine in your office and some Benadryl injection. But that's going to be up to the discretion of how you think they're looking and feeling. When we're looking at the treatment of a small to a large local reaction, then you want to remove the stinger. You want to wash with the wound, do cold compresses, oral antihistamines, oral anti-inflammatories, and elevating the extremity. So when we think, let's just go over a few of these. When we're thinking about pain management, it's usually commonly that we use the NSAIDs or Tylenol, the acetaminophen. And with wound cleansing, the bites and scratches really need to be cleansed with mild soap and water and with betadine solution to remove the animal saliva from the wound. You want to get rid of all that particulate matter. And if the bite was caused by a potentially rabid wild or domestic animal, then you need to be wearing protective gloves. Make sure you're really irrigating that wound with benzalkonium chloride, and that is because that has been used to be capable of inactivating the rabies virus. And then wound irrigation, you can do the wound irrigation with the betadine. Debriding the wound may be necessary. Closing the wound, let me talk just really briefly about that. When you have a facial bite without any signs of inflammation, you should be able to close the wound after thorough cleansing and preparation. But bite wounds of the hand should not be sutured. For bites to other areas in need of closure or bites greater than 24 hours old, you may need to have delayed primary closure. Tetanus bites, tetanus immunization for bite wounds, you should be giving that if they have not had a boost. If they've not had a booster within the past 5 years, then you should give them a booster. For antimicrobial therapy, so let's think about this for patients who come in and they have a cat bite or a human bite. They should receive antibiotic prophylaxis for at least 3 to 5 days if the wound is a fresh bite wound. So if they were bitten by a cat, if they have a hand bite, if they have moderate to severe tissue damage, have a wound that may involve a tendon or a bone or a joint, or if they are immunosuppressed, then they need to have some type of antimicrobial therapy. Patients with infected wounds should be given antibiotic therapy based on the results of a culture. So the most common causative organism after an animal attack is Staphylococcus and Streptococcus. The antibiotics should be given if there's less common pathogens such as the Pasteurella or the Echinella. When we're thinking about human bites, I'd like to use the amoxicillin clavulinate for 3 to 5 days. And if they're having a lot of GI side effects, then you can always do an alternative of cefuroxime for 3 to 5 days. They may need to be admitted to the hospital and have parenteral antibiotic therapy for all significant human bites to the hands, especially closed fist injuries and bites involving penetration of the bone. Very important. You don't want them to get a nasty infection and lose their hand. Rabies prophylaxis is significant. If a dog or a cat is healthy and available for 10 days of observation and they show no development of rabies, then you do not need to treat that exposed person. But at the first sign of rabies in the dog or cat that's inflicted the bite, then you have to begin treatment. So 85% of all cases of animal rabies in the United States now occur in the wildlife. So, you could be bit by a skunk or a fox or a bobcat or a raccoon or whatever, but the risk of rabies in rabbits as well as mice or rats is minute. So usually they're not causing you to get rabies. If you have post-exposure rabies, post-exposure rabies is indicated, then you would need to look further at the treatment for that and how to give the prophylaxis on those patients. You can also do a brief course of oral corticosteroids in these patients, as well as high-potency topical steroids, which we talked about, for 1 to 2 days, and usually that resolves it. if they're in your office and if they present with difficulty breathing and they come to your office, which they do all the time, then you need to give them a shot of epinephrine and get them out to the emergency department as soon as possible. I always make sure that my patients that are allergic have an EpiPen on hand and that they know how to use it and they're instructed how to use it. It comes in a pack of 2, so you can give them one for home and one to carry with them in their purse or their car or whatever. And then, educating them on how to avoid the insect bites. Most people know this. If they're allergic already to something, they know they need to avoid it. But if they're not, if they really don't know that they're allergic, obviously they don't know till they know. And so they may need to wear a medic alert bracelet if they've had an anaphylactic shock from a bee sting or from anything else, a spider bite or whatever. And then a lot of these patients will go to the emergency room and they'll do a follow-up with them in 12 to 24 hours. You can also do the same if you've given them something in your office and they can go if it's been a very mild reaction. This is just a picture of a larger local reaction to an insect bite. You can see all the erythema surrounding this nasty blister, which will most likely pop and cause an ulceration. Same as these here. They may show up as a small red area, and then it eventually starts to blister. Now, this is kind of similar to how fire ant bites are, but they don't get this blistery appearance. They get more like a big white pus head on them. And then if you pop that pus head, they stop itching. But until then, they itch intensely. I want to talk just a real quick on 2 different spiders. One is the brown recluse and one is the black widow. The brown recluse spider is usually... it's seen more in the Arkansas, the southern Missouri area. It has been known to be in other areas too, but this spider lives in old boxes and it lives in furniture. It's very easily transported to other areas. So if you move from one of those areas, it can definitely be transported to another area that doesn't usually have these in the location. Be very cautious when you're putting your hand in wood piles, when you're going into a cellar and sifting through things or packing things up, because that's where they like to hide. They get that fiddleback. The fiddleback spider has that characteristic violin shape on their dorsum, so it's on the head and the body section, and it contains a cytotoxic venom, which actually causes local tissue destruction, and the necrosis can occur very quickly with these. So your patients may present where they have just some mild inflammation, some erythema, and some swelling at the site of the bite, but then it really can extend very quickly within sometimes 48 hours into actually like a hole. It almost looks like a hole where the spider bite has burrowed down into. And I've actually had to repack patients for a month with iodoform gauze until they've had healing of the wound. I've had patients come in with it on their inner thigh. I've had patients come in with it on the back of their leg. I've had patients come in with it on their arm, where the spider had jumped down on one man on his arm and he didn't even know it and bit him when he was in the garage doing some work. The other, and you really can't, there is no test to say this was a brown recluse spider, or this was a brown black widow. There's no testing for that. But if somebody can capture the spider and you can actually see it, then you can identify it and know what it is. But other than that, there's nothing really you can do. The black widow spiders are found throughout the United States, and they're a lot down here in the South. And we have to check our furniture on our patio down here in Florida. We check it about every other week. My husband turns over all the chairs and looks at everything because they get this. When they lay their eggs, they envelop in like a little round ball, and you have to actually kill that little round ball because there's trillions of spiders inside of it. We check it because the grandkids come in here and they sit on the furniture and they're jumping around, and they could loosen one of them and a spider could come out. So we check our furniture pretty frequently for those. They usually are around the houses. They're in the garbage, in the garages. They're in sheds. You may see them in crawl spaces, in rain spouts, somewhere where it's moist. The female spiders carry the characteristic orange-red hourglass-shaped marking on that ventral abdomen, and they're the most feared spiders because they injure their victims by injecting one of the most potent venoms secreted by any animal. It is neurotoxic. It acts on the myoneural junction, and it exerts its damage by releasing acetylcholine and norepinephrine. So they're not nice. They're not nice spiders, and they're very dangerous. Treatment, usually ice, irrigating, elevating the wound. We talked about all of these, getting a tetanus, but hospitalization, and it really is going to depend. A lot of these patients with one of these bites will go to the emergency room or go to a walk-in center or an urgent center. So you may see them there versus them coming into the office. But as I said, they do have some rapidly expanding lesions that occur, and usually within 48 hours, they see that nasty burrowing sensation of the wound. This is a brown recluse spider bite, and this is just a very small bite that has not gone into, it's an early stage, it has not gone into a blister. This is actually the blister that will form before the tissue starts to necrose. So these patients need to be told very clearly that if you ever experience one of these bites, or if you think you did, and somebody comes in like this, or they'll tell you, I've seen spiders around my house, they need to be told that they need treatment immediately if they would ever get bitten. There are patients who do come in and say, I've been seeing a lot of spiders in my house lately. And you have to kind of tell them, is it a spider that's got an orange-red hourglass shape? Is it a spider that has that fiddleback shape to it? And you may need to question them. I was watching a show the other night, and they had a patient who got his sheets fell on the floor while he was sleeping, or the blanket fell on the floor while he was sleeping, and he was chilly. He picked the blanket up, and there was a brown recluse spider in there, and it bit him on the leg, and he ended up with 12 days in intensive care because it was nasty. They had to debride it. They had to cut it open. It was really pretty bad. A couple of the other things that you might see too, I'll just touch on this briefly, is scorpions. Sometimes they get under rocks and logs and floors. So, if you have carpenters and they're doing anything, you need to be suspicious of that if they come in and you ask them what kind of work that they do, if they have a bite on them. The ticks, we see a lot of, in the northern states, we see a lot of patients come in with tick bites, and you need to be thinking about Lyme disease and treating them accordingly for that, testing them accordingly for that, as well as mosquito bites. We've had a lot of problems down in Florida with the Zika virus with pregnant women. So, these we have to be very cautious about now. And there's a really good video that is in the module on brown recluse bites that you can watch.